It's very exciting that last year the LLM conference for the first time added benign hematology, or I should call it non-malignant hematology, to the agenda. And ITP, or immune thrombocytopenia, used to be purpura, is now a big part of non-malignant hematology. I'm going to review some of the topics in that in regard to, first, issues in diagnosis, which have become very big when you compare ITP to leukemia in terms of the diagnosis. The best thing you could say about ITP is the diagnosis is primitive. There's no specific testing. There's not a lot of categorization into subgroups, and more or less every patient is treated the same, which for leukemia would be like saying ALL, AML, CML, and CLL are all the same, and they should just be treated identically. So reviewing some of the details of what you can do is very important to prevent misdiagnosis, which has been surprisingly frequent even in experienced hands. A second feature, obviously very important, is treatment. And there are a number of new treatments of ITP and a number of important changes in established treatments. The ASH guidelines in particular and the International Consensus Report have made a major focus on cutting down the dose and duration of steroid use. And that's a really big part of management of ITP. This means bringing so-called second-line agents into play much earlier, certainly within 3 months and possibly even within 1 month of diagnosis. Recent flight trials suggested that there would be advantages possibly to using more aggressive therapy at diagnosis, and the limitations of that go back to the whole issues of diagnosis. Also, prognosis. You don't want to be treating extensively somebody whose ITP might be about to go away. Finally, there's a new onset, if you will, of ITP related to COVID vaccination. And this is with all kinds of vaccinations. This is different than the thrombosis and thrombocytopenia event that seems to be linked to the adenoviral vaccinations, so those of Johnson & Johnson and of AstraZeneca. In the COVID vaccination, you can get de novo ITP developing, which fortunately seems to be able to be managed by standard therapy the great majority of the time, meaning steroids and IVIG, but very rarely leads to something more serious. And then in particular, patients with ITP who would be obviously at high risk of worsening their ITP with a COVID vaccination, but nonetheless need it. We showed in an article that's now online in Blood that the people at highest risk are those who have had a splenectomy and those who have had many treatments in the past of their ITP. So there are many developments to discuss and review at the conference, and it's a great pleasure to be able to participate yet again in such a wonderful event. Thank you.